For those that don't know me, I'm Brendan Ebi, so I'm one of the WashU neurologists. I'm stroke and interventional neurologist, but I'm also the medical director at St. Peter's. I'm very involved, obviously, with our stroke program, but the system thrombectomy program, so I spend a lot of time in that. And then today I'm going to be talking about posterior circulation strokes, which is...
Do the down button, it's the opposite. Yeah.
Okay, thank you. Posterior circulation strokes, which is relevant to some of our patient discussions later today. So a couple of disclosures. I have given some talks, educational talks, but supported by industry. So Penumbra, as well as Route 92, the company that got us lunch today. So, you know, I've done them some favors and they were able to do us a favor today. But none of this talk is about specific devices or thrombectomy techniques, you know, so that's not a takeaway here. But another disclosure is that this is actually very similar to a talk I gave a couple of years ago. So if you guys were here in 2024 and my jokes sound corny, well, they're still going to be corny, so sorry about that. You're just going to have to deal with it. But let's kind of dive in. So this is a great kind of extension of that same conversation, you know, this of the last patient, you know, the strokes. Basically, this is my, you know, why do I care slide that everybody has in their talk, but I think we all know that stroke is a big deal in the United States. It's the 5th leading cause of death. That was true in 2020 in the middle of the COVID pandemic, if you check the CDC website. And so it is something that affects a tremendous amount of people across the country, but not just with death, but also with disability. That's a big problem because not everybody dies from their stroke, and a lot of people live with paralysis, aphasia, so trouble talking, and other very detrimental effects of these strokes. And so anything that we can do to try and manage a stroke better helps a tremendous number of people in our country. But to back up a little bit, you know, when we talk about stroke, you know, it's not as clearly defined. You know, so we talk about ischemic stroke, which is blockage stroke, and hemorrhagic stroke, which is the bleeding type stroke, and that was obviously very prescient in our last conversation. But, you know, why do we call them both stroke? Well, this is the same kind of concept that I think you guys in EMS deal with all the time. Because when you go see a patient in the field, you don't know what kind of stroke it is, and it looks the same. So the term stroke came back from this old concept where people look like they were just struck down by the gods. So one day somebody's doing fine, suddenly they are afflicted, and now they're paralyzed, you know, weak, can't move, and it happens, you know, like a lightning bolt. And so, you know, the assumption was that they, you know, offended a god, you know, in this life or maybe a past one, and then this is their retribution, and then they have to live with that damage. And it was really only until modern science that we were able to first hone that it was a vascular issue and then separate it between ischemic and hemorrhagic. And, you know, when you get called into the field, you don't know if they're bleeding in the brain or if it's blood clot. That's part of the reason we can't just give, you know, blood thinners or clot busters, you know, before they get in the hospital. We need that CT scan. But here the focus I'm going to be talking about is ischemic stroke, which is blockage type stroke. And the main reason for that is that that's the lion's share of what we deal with. So I love this graphic every time. There are a ton of different hemorrhagic strokes. So I guess for the people online, I'll try and use the cursor here. But those are all differentiated in these like 12% of what we call stroke. And then everything else is ischemic stroke, which is, you know, essentially related to a blood clot or blockage. And so, you know, with a focus on that, you know, that's obviously kind of the bigger impact. But of those, we subdivide them in a lot of different ways. So we can have embolic strokes, which are clots that travel from somewhere else, thrombotic strokes, which can be a, you know, clot in the artery. But another delineation is kind of the symptoms or which artery is affected. And so that's where we come into this idea of posterior circulation strokes. So posterior circulation, why do I have a horse's butt on the screen? And it's actually not a horse, it's a zebra. But posterior, when it comes to anatomic terms, just means behind or back. I remember being a medical student and being so confused, like we would talk about like this superior and inferior mesenteric artery, and I was like, what makes it better than the other one? But superior just means up, and inferior just means down, and anterior is front, and posterior is back. But here we're talking about the posterior circulation, which means the backside circulation of the brain. And also I found this photo is fairly relevant because in medicine we talk about rare conditions as zebras. There's a phrase to like, to keep you from thinking about the rare stuff. They say, when you hear hoofbeats, think horses, not zebras. But it's kind of morphed into talking about looking for zebras, which are the rare things that still look or sound like the normal horse. And that's the case here. So most strokes are of the anterior circulation, the front arteries, the carotid arteries. Here, the posterior circulation is rare, about 20% of the time. But it's actually really quite important real estate. So this is kind of what we're talking about, the posterior circulation. You have the carotid arteries in the front, but then two vertebral arteries, and they run up the vertebrae here in the back part to supply the back part of the brain. So these are the arteries coming up the vertebrae, that's how they get their name. They go through the bones, and then they join together to make this basilar artery in the middle. And that basilar artery sits right on top of the brainstem. So this is a front and a side view of the brainstem. And then the kind of like most posterior, so back and lower portion of the brain is the cerebellum. And so it supplies the brainstem and the cerebellum. Not only is this a unique kind of circulation compared to some of the other strokes, but it's also really critically important. And that's mainly because this is a pathway for most of the nerve endings and communication of the brain. So you guys probably have heard the brainstem and recognize it's really important, but why is it so important? Well, for the brain to get signals out to the rest of the body, it then sends those signals through the nerves, the axons running through the brainstem, down the spinal cord, and out the nerves to the rest of the body. And so I have this is the like a map depiction, the phrase, all roads lead to Rome. And so this is Rome down in Italy and all of the roads branching out that you can make a connection. It's the same kind of thing. All of these pathways run the same channel through the brainstem, which makes it really quite high-priced real estate, but it also means that it can affect people in basically on all parts of their body, despite being only one segment, where you normally, we have some idea about what side of the carotid is the problem with anterior circulation strokes. Here, it kind of controls everything. And so what does that mean? Well, obviously, each of these branches supply different territory. I have some slides here to kind of talk about the anatomy, but I just want to kind of gauge us into, this is a nice little graphic depiction, but this is actually what the arteries look like. So this is an anterior-posterior angiogram, so similar to the case from the thrombectomy. But, excuse my scrubs attire, but Thursdays tend to be my procedure day, and so I was doing some angiograms and just looking at these vessels just a few minutes ago before running over here. And this is what we actually see. And, it's not as nice as the cartoon, but they have a bunch of branches off of this main artery, the basilar artery. And each of them supply a different area, and when they get blocked, it's a different type of stroke. Kind of marching from the top down, and I'll go kind of quick through this, but there's the posterior cerebral arteries, which supply the occipital lobes. So this is like the vision centers for most people. And then if you go further down, there's the superior cerebellar artery. Again, anatomic terms, but basically it just means the top of the cerebellum. So this is a side view MRI. Here's the eyeball and nose. This is all the way back, and you can see the cerebellum back here in the top part. But blockages here mainly affect the cerebellum, so that's ataxia, which is clumsiness, and can also have trouble with vision, double vision, so the eyes don't move well. If you march lower, this is the anterior inferior cerebellar artery. Again, we're just naming where it goes and what it supplies. So anterior front and inferior slightly lower part of the cerebellum. That's what this MRI is showing. So the kind of the front and the bottom. And then moving further down, and usually off of the vertebral artery and not the basilar artery actually, is the posterior inferior cerebellar artery. So the bottom of the cerebellum gets supply kind of front and back with these different. And so blockage in any one of these can cause some unique syndromes. For instance, so just to give you an example, that posterior inferior cerebellar artery has this interesting syndrome that we all have to learn in medical school. It's called Wallenberg syndrome. It's named after the guy that kind of found it, but it's technically a lateral medullary brainstem infarct. But it provides the great example of this weirdness that is the brainstem and how all the tracks run through. So you can see the stroke here. This is cerebellum damage, and this right here is brainstem damage. And mainly this brainstem damage is what, it's much smaller, but what actually affects the patient a lot. But it means that they get dizzy, probably because of the cerebellum and cerebellar tracts. But then they get numbness on one side of their face, the same side of the stroke. But where this is at, it's where the fibers are crossing over from one side to the other side of the spinal cord. And so the numbness is one side of the face, but the other side of the body. But on that same side of their face is where they tend to get the clumsiness. So they have numbness on one side, but clumsiness on the other. So it becomes a very confusing picture when you're trying to do this evaluation. So one of the things that I would always tell you, trying to differentiate posterior strokes, is that just because it doesn't add up, that actually should be a signal to you that maybe the stroke is in the back part of the brain. Or more importantly, just because they're complaining of weakness on one side and numbness on the other, or clumsiness that doesn't all match up, you can still keep stroke in your differential. That should still come in as a code stroke, right? And so then, these become very difficult to identify because they don't usually fit that clean box, like face, arm, leg, same side of the body. So, I had ChatGPT create a nice little graphic to talk about things that you can look for. But I realized that we actually already talk about a lot of these things. So you guys know that we used to use the FAST mnemonic to identify stroke, and we've now moved it to BFAST. That's been honestly a big push in the last few years. But basically each of those letters give you symptoms that you should be looking for. So B as in balance, E as in eyes, F is face, arm, speech, and the T, time, just means get to the hospital quickly. The whole point of that B and E is for posterior circulation. Because as I mentioned, occipital lobes, PCA, or eye movements, so eye issues is posterior circulation, and that clumsiness, the vertigo, the dizziness that tends to come with a lot of these, that's the balance portion. So sudden onset of all of these things still should put you in that bucket of stroke. So, and then here are some other things that you can think about, which would include, if we call them cross symptoms, so like one side of the body, or one side of the face and the other side of the body. And then another possibility is that if it shuts down the whole brainstem, suddenly then they're comatose. So, that can be a lot of different things, but one of the scary things could be stroke. So that should still be on your differential. Just a quick call out here. I mentioned dizziness, and this becomes one of the really tricky ones. I'd say from an EMS standpoint, the take-home point would be sudden onset dizziness should be thought about like stroke, okay? But for like nursing in the room, and the other physicians, right, you guys know how difficult it is for us to try and figure out where that comes from. So a couple of things that I'm thinking about when I get called to a room to evaluate a dizzy patient. Well, first, so this is central versus peripheral, and what that means is essentially brain problem versus inner ear problem. So central is brainstem, and peripheral is ear. And how can I kind of differentiate the two? Well, one big clue is if they're having other stroke symptoms. So yes, they're dizzy, but are they also slurring their speech? Do they have weakness or clumsiness, right? Do they have vision issues? It's normal for their eyes to be jumping in both cases, so nystagmus. But if they're having actual double vision, like if you cover up one eye and the double vision goes away, but they're opening both and they don't line up and they're getting two different pictures, that's a concern that the eye movements are abnormal. Another one is that the dizziness sticks around, right? So if they're able, if it's an inner ear problem, a lot of the times it has to do with the position. So yes, moving makes a dizzy person worse regardless. But if they sit absolutely still, can they get it to calm down and go away entirely? And some of these people who deal with long-term dizziness or vertigo, they'll tell you like, oh, I just can't turn left, but then I'm good, and then I sit still, right? But then I turned left, and now I'm dizzy. And you're like, that's probably not a stroke, because there's only like one specific movement. You're triggering part of the inner ear. Whereas with the stroke, that's damage to the brain, and it doesn't really kind of matter which way they're turning. All you're doing is sending signals to that damaged area and getting it irritated. And then, I'm sure you can kind of read ahead on some of the slide, but some of the other things that we ask about is like dizziness versus lightheadedness, right? So vertigo is like a room spinning, like you're on the merry-go-round. I think we all remember like being a kid and spinning our swings, in a knot and then letting go and then like getting off of it and not being able to feel on the ground. That's really what we're talking about on vertigo. For like that lightheadedness, like I feel like I'm going to pass out, I'm getting sweaty or clammy, that makes me think more like heart issues, blood pressure issues, syncope, than dizziness. But the truth is, if you have somebody who has sudden onset of dizziness with any of these symptoms, you still need to think about stroke. So it's always appropriate to start with an idea of stroke rule out, the code stroke, and then back off as we try and differentiate it. So, it's not that big of a deal, right? Like I would rather that we don't miss these people. And then even if all they have is dizziness, that's probably worth a conversation, at the stroke spot or whatever to figure out if we need to do anything more. So let's presume it is a stroke. Well, posterior circulation also doesn't tell you anything about the cause. It's just telling you the location. So all of the causes of other strokes is true here too. You can have damage to the artery and thrombosis, buildup of plaque, atherosclerosis. You can also have a blood clot that travels up one of those vertebral arteries. That becomes tricky too, because if it hits more than one spot, it can cause a lot of trouble, and it can be hard to figure out exactly where we would localize the stroke. But either way, we still consider them for all of our treatments, TNK and thrombectomy. But the posterior circulation does have some unique qualities. So one of the biggest difficulties is that it's not just high-priced real estate, but it's also really quite constrained. You have the posterior fossa, which is the back part of the brain, just inside the skull here. And then you have the dura. This is an area called the falx. But basically, the lining of the brain is really thick on top of the cerebellum. And what that functionally means is that you've got a really small space in the back part of the brain. So you can't tolerate as much swelling if somebody has a bleed or swelling. So that's what this is really showing here, that you might deal with decompensation in the area of herniation. So this is another reason that it's important for us to identify. Even if they're not a candidate for acute treatments, they might still be at risk for pretty quick decompensation. These are patients that we have a pretty low threshold to move to the BJH neuro ICU and watch them really closely, because if they start falling off the cliff, they'll fall quickly. And then we might have to do something like surgical decompression, take some of the skull off, or at least give them the medicines to try and help with the swelling. And then, this can have some long-term issues, right? So even if it's just some dizziness or some trouble walking, that's actually really quite impactful for a lot of these patients. So these have a disproportionate amount of trouble swallowing and also difficulty walking. Whether there's vision loss or balance issues, right? It doesn't matter if their legs can work, have strength. If they can't coordinate them, then they become quite disabled. So that, unfortunately, this have kind of an outsized impact on people. And then there's one other kind of stroke syndrome that I do want to call attention to, and that's specifically the basilar, right? So that's that main blood vessel. We talked about those branches blocking, and that's a problem. But what if the whole highway gets blocked? Well, that becomes a real big issue, right? And basically, it's a shutdown of the brain. So they might have profound weakness, numbness, trouble talking, but they also might be comatose, so a sudden onset coma. And so, this is, kind of the talk for the EMS. If they were like, oh yeah, he suddenly won't wake up at all, that's still a consideration for stroke. And then in the ER, I would really encourage us to get a CTA, because then we can know for sure if the basilar is open. Because this is a really bad problem, right? Obviously, it's shutting down a huge part of the brain, and a lot of people die from this. But there's also, it can cause a lot of permanent damage. And there's this entity, kind of like a fate worse than death, that I'll tell you as a neurologist, I really kind of fear in this situation, like if I ever had to go through it. Have any of you guys heard about locked-in syndrome? So basically, a stroke in the back part of the brain that paralyzes both sides of the body. Somebody is completely paralyzed, but it hasn't damaged the rest of the brain. They can still think, they can still feel, they can still understand, but they can't move anything. You're paralyzed inside your own body. The traditional one, all they can do is maybe blink or move their eyes up and down. And otherwise, they can't do anything. They're fully dependent. And so, I mean, that sounds terrifying. So this is probably the most famous example of locked-in syndrome. This was an editor for a French magazine who suffered a brainstem stroke and locked in, and he published a book. So he wrote and published this book, The Diving Bell and the Butterfly, and he did it. This is a picture of him with his, I believe, wife, and who was also assisting him with it. And what they would do to write the book she would read out the French alphabet, and he would blink to stop on each letter to put together every word so he could spell out his entire memoir. He was doing it at a rate of 1 word for every 2 minutes. So, I mean, that's insane. But if you really want a good description of what it would be like to live in that condition, you should read that book. So, if I have not scared you enough, then I do want you guys to think about basilar artery strokes. And then another really relevant part of that is because we now really have good evidence that we can do something about it. So to transition a little, and I can really gloss over these slides, but thrombectomy is obviously a very big interest of mine, but it has been a kind of a revolution in stroke where we can go in with a catheter and pull out the clot and try and reperfuse the brain, get the blood flowing again before it's died. So, this is a great thing. We know these large vessel occlusions are very problematic, right? But all of the studies that came out in 2015 that got us all really excited, they didn't look at the posterior circulation. They wanted to look pretty specifically at carotids, ICAs and M1, so the middle cerebral artery. But basically, back when I was saying, like, when you design a good study, you want to be pretty specific about what you're looking for, and the posterior circulation is really difficult. 1, it's hard to find. 2, these patients do poorly, so maybe they were worried that even if we did everything right, they would do poorly, and that might make it look like all of these treatments didn't work. So they said, we're not going to deal with that right now. We're going to do it in the front and the carotids and prove that it worked, and they did robustly. And so these patients had excellent outcomes. This is kind of what we tend to look at when we're looking at thrombectomy outcomes, but basically this is a measure of how well patient did. 0 to 6, where like 0 is no symptoms, 1 is minor symptoms, 2 is still can live on their own, and 6 is dead. And usually we think kind of a 2 or less means a good outcome, where they can basically function on their own. And it showed that where like only 25% of people were able to live on their own after this treatment, closer to 50% after doing these thrombectomies can improve. And we've already shown an example, but like these can be very dramatic where there's a blockage of a whole hemisphere, and we pull out the clot that looks like this, and then it reperfuses. And so we had guidelines since 2015 saying we should be looking for and taking people for these. But you will notice that they were very specific, and they said in the carotid or the MCA M1, and nobody talked about the basilar. And so since then, we had to have multiple trials to see if this worked. And unfortunately, the first couple were non-significant, so we couldn't really prove it. There was a signal. The numbers look better for the MT, that's mechanical thrombectomy, versus control. If you go down those middle columns on both sides, the numbers look like they favor, but as you guys know from statistical analysis, we have to prove that can't be done with chance, and they weren't able to do it until these 2 studies in 2022, which really kind of opened up the field. Both of them were published in a major journal, New England Journal of Medicine, and they really showed quite a dramatic improvement in functional outcome here. So that same error bars, you can see how much they're shifted. The tricky part here is basilar is really bad, okay? They even shifted the goalposts here, because what you can see here is, so the control group is a basilar stroke that doesn't get thrombectomy. They literally had 1% of people who made it through that and didn't have any symptoms. So, and only 7% only had minor symptoms. 14% were able to return to their regular life, which means 86% of people were substantially disabled. So in this one, they even fudged the math a little bit. And instead of saying a good outcome is up here, they even said even moderate disability, like as long as they can walk, right? Like if they need help to the bathroom, but they can walk and maybe tell you kind of what's going on, then that's a good outcome here. And even then, there was a dramatic shift, but we're talking about almost 40% of people who got the treatment versus, 25% of people on the other group. So, it still can be pretty devastating. But with that, they put all those studies together, and I don't know statistics all that well, but I love these forest plots because I feel like they make it really simple, and they kind of stack up. You can really see how, so this is, treatment versus medical management, and all of those are lining up on this side. So it really emphasizes better outcomes, and this means more deaths. So more deaths in the medically treated. So that means that we save lives, we save disability. There is a slight increase in the risk of hemorrhage from doing this, and that's what that middle one is. So it's not benign, but we help a lot of people. And so just this year, they published updated guidelines actually supporting that we should be taking these people for thrombectomy. Now, I'll tell you, my group has believed this kind of before the data was published. We'd consider this kind of a heroic measure because there can be some terrible fates from this. But even after those studies, we were routinely taking these patients. But more of an emphasis that I do want you guys thinking about posterior circulation and especially basilar, because we've now proven that we really can make people a lot better doing this treatment. And so a couple of examples of that thrombectomy. This is the same kind of image, but you can see where that basilar stops here. And then opening that up, kind of reperfusing all of this. So this would have probably been a very disabling stroke. This is a slightly nuanced difference, but it's still a basilar thrombectomy. This is kind of on top of the basilar. So the clot is sitting kind of right over can you guys even see my cursor? No? Okay, well, I've been doing that the whole time and it hasn't worked, but the laser pointer doesn't help either. I can walk and move, but the top of the basilar here is occluded, and so there's poor filling in the posterior cerebral. There's no posterior cerebral or SCA on this side, but there is a portion of the brainstem that is still perfused, but still it can be devastating. And so, post-thrombectomy, you can see all of that came back over here. And then sometimes we even deal with atherosclerosis. So this is one where there's like a mid-basilar occlusion. And so then we aspirate or, do our thrombectomy, and then we open it up, and you can see there's just a very small thread connecting them. It almost looks like a little jump segment. And that's, probably plaque buildup, atherosclerosis. But what we did was placed a stent in the basilar artery, which is definitely off-label, but I think, life-saving. And this is an example of a patient that did fantastic with that. So really happy with that outcome. So I guess with that, I do want to mention the references. If anybody has any questions or want any of these papers, let me know. And I will open it up to questions. I think I'm right on time.
No, you're perfect.
I have a question. Posterior stroke more likely to present like a comatose patient?
Well, that is one of the considerations. I'd say that's the most severe end of it.
So we're in the midst of rewriting a lot of our protocols right now, and it has come up through provider inquiry to us, and we didn't have a solid answer. Of course, I would ask Dr. Pantherton too before, but the idea of pre-activating a potential post-stroke on an unconscious of unknown origin. What is your thought on that? Because we throw like the kitchen sink at it pre-hospitally, and sometimes that still doesn't result in anything.
Yeah. I think that's great. My bias is that I want to treat more people and see more people. So my first thought is that I would say let's absolutely include that, and if that helps them. But I think that you could refine it a little further where there are kind of two things that you had mentioned. One is unknown origin, and so if we really don't think that if we have any evidence or even suspicion that it wasn't kind of like sudden onset, like there's some talk about a decline over hours, they had other symptoms, or during that assessment and workup, you see that they're like fluidly hypoxic, their blood pressure is through the floor, you have other things that are pointing you to another cause, then those might not be as high yield. However, on the contrary, if you don't have a good explanation, the vitals are okay, whatever, the glucose is okay, and they're still comatose, then I would absolutely say that needs to increase your suspicion. And those would be patients, in my opinion, it's very simple to get a CT and a CTA to rule out the most devastating, one of the most devastating possibilities and actionable ones. And if that's clean, then you log that away, we know that we didn't miss it, and you can kind of transition. And so that would be, I think, a situation which I would encourage us to consider that in the code stroke pathway. So yeah, especially if there wasn't a clear abnormality that we can address, like hypotension, and we fluid resuscitate them and they're perking back up, or you give them Narcan and they start swinging at you or whatever. Yeah. We've all been there, right? You guys much more than me. I remember the days in the trauma bay, and it is really quite traumatic. Other questions? Otherwise, a perfect talk. I appreciate it. Thank you. What an honor.